Good afternoon, everybody. Today I'm going to talk about my dissertation study, TELECARES-NI, which is telehealth, cardiac education, and support by nursing intervention. I'm from the nursing department, clinical assistant professor in the College of Nursing and Health Sciences. By way of introduction, the Internet. The Internet has evolved rapidly in the past 10 years. In 2002, 73 million persons in the U.S. sought health information online. Of the Internet users, 46% looked online when they needed reliable health information, medical information, as opposed to contacting a professional. By 2005, more than half of the U.S. healthcare consumers would have access to the Internet from home or work. Now, this is what was prophesized at that time. By 2009, things had changed a bit. 75% of adults knew how to find information online. 61% of adults now will look online the next time they need reliable health or medical information as opposed to contacting a healthcare professional. Activities include reading others' commentary, reading others' experiences, consulting rankings or reviews of providers and facilities, receiving updates, interacting with other patients, and listening to video or podcasts. This information is from the Pew Internet and American Life Project, and if you go to their website, they have a store of information all about people using technology, not only the Internet, but at this point, cell phones, all sorts of electronic devices, do it by age, by ethnicity, very interesting articles. Cardiovascular disease affects 82.6 million Americans. Annually, there are 5.9 million cardiovascular hospital discharges in the United States. Over 6.8 million cardiovascular surgeries and procedures are performed. Heart disease claims over 1.3 million lives and represents over 33.6% of all deaths. The trend towards healthcare constraints has led to a decreased length of hospital stays, making each admission more activity intensive. So you may be in the hospital for only 2 days, but you may have a lot happening. You may have an angioplasty, you may have chest pain, you may have a heart attack. Everything is squeezed in, whereas before you might have stayed a week or 2. And at this point, sometimes people with bypasses will go home in 4 or 5 days. Now, what is the problem? The problem is little was known about cardiovascular patients that use the Internet. Who are they? What are their diagnoses? How much support have they received? What concerns do they have? And how would they respond to online nursing intervention? The aims of this study were to seek out cardiovascular patients who already use the Internet, find out who they are, offer them online nursing intervention, and then compare the results to those who do not receive the intervention, and then determine if there is a difference in outcomes. The guiding theory for this study is a theory I developed during my doctoral studies called the online social support theory, which specifies that if there's an alteration in health status or an alteration in perceived health, which you'll see over on the left, can be acute or chronic, and then you need to look at what are the indicators. If you have health problems, perceived individual factors, demographic factors, or other types of factors such as information, you filter that through the lens or different filters inside your brain, which would be the transactional filter, the cognitive filter, the perceptual filter. You can provide support, information, education. This could be qualitative or quantitative. And then in the end, this could be linked to all other things that are going on in cyberspace. This could be at an individual level, a group level, or a community or organizational level. And as you increase your organization, different networks are formed. This is called linking. Sort of a little takeoff on the web use of linking in that everything is processed in your brain and comes together in order to provide social support and receive benefit from it. Review of the literature. Telehealth is the use of electronic information and telecommunications technologies to support long-distance clinical health care, patient and professional health-related education, public health, and health administration. And that's from the U.S. Office for the Advancement of Telehealth, and that definition was put forward in 2003. Another definition that we need to know is telenursing, which is the practice of nursing over distance using telecommunication technology, and that was put forward by the National Council of State Boards of Nursing. Looking through the literature, a lot of the literature towards heart-related intervention started in 2002 with a study by Bennett et al. Called Heart Messages. It was women over 65 with heart failure. They were given tailored messages via web TV, which not too many people even know about that now. That is an older technology where you would have, instead of going to your computer to log in online, it was a program specifically on your TV that you were able to email and interact with other people. The patients were studied for their beliefs and barriers related to diet and medication compliance. They only received messages if they had barriers. They received age and race-specific videos and had a one-week telephone follow-up. In this study, the outcomes were equivocal. 3 patients improved, 2 were unchanged, 5 worsened. The conclusions were that it was a useful adjunct, and obviously the sample size was not very big. The biggest nursing study then and now is called Heart Care. This was done by Patty Brennan at the University of Wisconsin in 2001. She published in 2001, 2003, and then in 2009, Casper, who was on her study team, continued to write about it. CABG patients were given web TV, cardiac information, and support. Outcomes of the study were lower means on their physical dysfunction score, their symptoms, and their depressed mood. The composite odds ratio of this happening was 2.6 for weeks 1 and 4, and 1.08 at later times. So the differences were more pronounced in the beginning and were reduced over time. The design of this study is a pre-test, post-test, comparative control group, repeated measures design. There were two groups, the nurse support group, who received web-based discussion board for 6 weeks, and a self-care group who received web links only for 6 weeks. Patients or participants were measured at 3 times: the pre-test, the post-test period, which is after 6 weeks, and then there was a blackout period where they did not receive the intervention at all, and then they were given a post-test at week 12 to see if any changes that they any changes in their physical and mental status were enduring or not. The research questions, number 1, are there significant differences in psychological outcomes, physiological outcomes, support and satisfaction between persons with cardiovascular disease who receive internet-based nurse support or our self-care at the beginning of treatment and at the completion of treatment? Question 2 is, are there significant differences in psychological outcomes, physiological outcomes, support and satisfaction in persons with cardiovascular disease who receive internet-based nurse support or who are self-care at the completion of treatment and at 6 weeks post-treatment? Question 3 is, are there significant differences in usage as measured by frequency and duration of logins to the study website between persons with cardiovascular disease who receive internet-based nurse support or who are self-care? Question 4. What are the frequency and type of discussion board communications in persons with cardiovascular disease who receive internet-based nurse support? Question 5. What are the frequency and type of educational and supportive nursing interventions posted to the discussion board in the course of internet-based nurse support for persons with cardiovascular disease? The process variables, in here we divided these into process and outcome variables. Usage is the number of logins to the study's website within 6 weeks. Communication is the number of postings to the study website in 6 weeks. Nursing interventions is the number of nurse support interventions over 6 weeks. Then we have the outcome variables. The outcome variables are the psychological outcome, which is the SF-36 Mental Component Summary Scale, also known as MCS. Physiological outcomes, which is the SF-36 Physical Component Summary Scale, the PCS. Support was measured by the Perceived Social Support Scale, also known as PSSS, and satisfaction was the LaMonica-Oberst Patient Satisfaction Scale, or the LOPSS. Methods. Patients were recruited from general websites, from health websites, for instance WebMD, cardiac-specific websites. There were some specialty groups for patients that might have had bypass surgery or defibrillators, and there were specialized websites, like the people that had heart surgery called themselves the zippers, because they had big scars on their chest, and then the people that had defibrillators, they called themselves the zappers. You know, they had their own little names for each other. They were also recruited from news groups and from listservs. Data collection was via a web-based form, and all the information was entered into a database immediately. This was what the website looked like, the main page. And a new user, there wasn't much you could do unless you were registered. You could subscribe to the newsletter, and that was for people who were interested in hearing about the study. About the study was just a page with information, basically about the study. New user, where you sign up, and then once you've signed up, then you log in, and then other than that, you couldn't see anything. Analyzing data, we used MANOVAs, which is a multivariate analysis of variance, and did two types of MANOVAs. One is between pre-test time and post-test 1, and the other one was between post-test 1 and post-test 2. The variables used here were psychological outcomes, physiological outcomes, and support. The reason we did not do a full MANOVA between all 3 time periods was because after the 6 weeks, a lot of people that did not receive the intervention initially, even though they were offered it, did not want to come back. So we would not be able to analyze all those people between time 1 and time 2, so that's why that was chosen to be done statistically that way. We did univariate ANOVAs and satisfaction, which was between post-test 1 and post-test 2, because obviously that could not be measured when they initially logged in because there was nothing to be satisfied about at that point. And also in usage, which was done during the intervention period. Results of the study: age range was 21 to 79 years, mean age 49, plus or minus 13. Education 15 years, plus or minus 3. Did not do like high school, college type categories because some of the patients were international and they don't have the same type of school system we have, so that's why it was measured in years. But as you could tell, you know, normally 12 years is high school, so this is probably like worth 3 years of college. Months since their cardiac diagnosis was 78 months, plus or minus 117 months. So it's a little bit over 6 years on the average. Most frequent responses were from females, 56.2% of the sample. Married, 78.6% of the sample. Annual income, $35,000 to $49,000, 18.6% of the sample. 38.2% were working full-time. 88.3% were Caucasian. Although we did try to recruit minorities, it was difficult, and I did go to specific websites for that, but predominantly Caucasian. 43.4% lived with a spouse, and 68.5% had private insurance. What were their diagnoses? 57.7% had CHF, 32.2% had chest pain or angina, 26.2% had MI, 22.8% angioplasty, 20.8% atrial fibrillation, 18.1% cardiomyopathy, 14.8% bypass surgery, 14.1% an ICD or internal cardiac defibrillator, 11.1% pacemaker, 9.4% were resuscitated or had been defibrillated at one point, 7.4% had received a cardioversion, 5.4% had valve surgery, 4.7% had a heart transplant, 3.4% had had episode of ventricular tachycardia, and 0.7% had an atherectomy. Research questions. Two results that were the same between two different time periods, between time 1 and time 2. The first one was between the beginning of treatment and the completion of treatment, so that was the first time period. Significant difference, and a significant difference between the completion of treatment and 6 weeks post-treatment. That was also significant at less than 0.05 level. In the psychological outcomes and satisfaction. Psychological outcomes improved significantly over time in both groups, and satisfaction was significantly higher in the nurse support group compared to the self-care group, which is what we were expecting, because obviously they were receiving support and the other group was more on their own. Then we had results that only occurred between the completion of treatment and 6 weeks post-treatment significantly. The effect for time was significant, and physiological outcomes increased significantly in the nurse support group, but decreased in the self-care group. So, part of what we're trying to figure out is that this happened because they received information on how to better their physiological state when they were having, if they were in the support group, and the others were not taking care of themselves. So that's the only, obviously can't predict that statistically because of the numbers, but that gives us an indication of things we could look out for. This graph shows outcome scores by group and by time. The first set is the nurse support group pre and the nurse support group post. Second group of graph of variables is nurse support post 1 and the nurse support post 2, so that would translate from 6 weeks post-intervention to 12 weeks. SC would be self-care pre and post 1, and then self-care post 1 to post 2. And over on the right you'll see the legend. The navy blue is psychological outcomes, the pink is physiological outcomes, yellow is support, and the little turquoise stars are satisfaction. So if you look at the satisfaction scores, those look higher, but actually a lower satisfaction level is better using that Lomonaco-Ober scale, so that the nurse support group was more satisfied at both times. The other thing that sort of is evident is that the support pretty much remains equal, and part of that was because the instrument we used did not really detect much changes in their perceived support, because it had subscales for family and friends, and that would not have been influenced by the intervention. The psychological, the most increases were in the psychological outcomes, as you can see with the navy blue lines between post-test 1 and post-test 2, where they both increased. These are the results of usage. These are frequency of logins to the website over 6 weeks by group. Patients visited 2,147 times. Those are the number of individual logins. And obviously you can see right here that the nurse support group logged in much more frequently than the self-care group, which is the way it was intended. This was, the intervention was supposed to be the, it has more things they could do once they logged in, and the ability to interact with other people. These are results of topics, and these are some of the topics. I had initiated 10 topics myself, basic topics like medication, diet, exercise, and then made the board available to let the patients put in what they wanted. And it was and most of it happened between Thanksgiving and January. So a lot of the chatter, some was chatter about the holidays. Some was about visits to the physician. Some were saying, I'm going to the physician, this is what I want to talk about, you know, what should I ask? And then other ones where I've been to the physician, this is what he said, what do you think about it? So it was a lot of really good information. And what we did is categorize this of what type of topics they talked about. There were 58 topics initiated, 330 replies. Topics included cardiac devices, diagnoses, cardiac rehab and exercise, cardiologists and physicians, debates, life, disability and limitations, fatigue, humor, inspirational quotes, mental health, talk about dietary supplements, symptoms and indications, social terminology and concept, social issues, and then terminology and concepts like, you know, what does this word mean? Tidbits, which was just they're passing along a bit of information to somebody else. Travel, and then the website itself, questions about the study. I also analyzed my own topics, going back over what I talked about to the patients. I initiated 40 topics and replied 257 times. Talked about their biographies. There was a section in there about how they ended up in their cardiac patient state, what was their history, cardiac diet, cardiac function, laboratory tests, medications, procedures, general information, stress and coping, web links, news articles, holiday greetings, because at this point we're getting into Thanksgiving and Christmas, and then the website and the study itself. These are the results of nursing interventions. This is a graph of the number of nursing interventions by the type of interventions. By far, I provided mostly educational interventions. Next one was supportive and reassuring, you know, like some especially after visits to physicians or worries about a particular topic. Next was no intervention. In some instances, I let the patients talk amongst themselves when I felt that they would benefit from each other more than they would benefit from me. Next was site navigation and the study protocol. You know, some were like, okay, well, what happens at 6 weeks? What happens at 12 weeks? And then we had counseling and coordinating interventions where it's like, okay, this is going to happen to you, you know, expect this, expect that, or this is what you should ask, those type of topics. And then social, which was primarily the holiday type talk. The conclusions of the study is that there was an increase in psychological outcomes in both groups at time 1, and that may have been due to the nurse email interaction, because some of them they did have my email, and they not only logged in, but they also emailed me. So some of them got a little bit more attention. But of course, once they emailed, they had to answer the email, so there was no way to really go around that. Secondly, the increase in physiological outcomes at time 2 in the nurse support group may have been due to greater well-being because of interaction, which we had discussed, because they learned more about their diet, their exercise, and what they should be doing. Number 3, satisfaction and usage were significantly higher for the nurse support group. And then the support was the non-significant. And then, you know, in the future, doing this type of study, I would use a different instrument that would be able to tease out any support they gained here. And the need for a more sensitive online support instrument. And, you know, I have looked at some since then, but if I replicate this study, I would, there's a couple that I would use now that are more tuned to the online environment. The limitations of the study. It's generalizable only to persons with cardiovascular disease who use the internet. The use of a convenience sample may limit generalizability further. Discrepancies between self-report data and actual physical condition are unknown. These were patients that were recruited on the internet. I did not see them. I did not know them. I did not have access to their medical records. So basically, you have to believe what they're telling you. We did have a sort of a trick question in, you know, when they signed up with their demographics, asked them what medications they were on. which I didn't really calculate that because there's so many different medications. But if those medications did not match their diagnosis, part of the study protocol was that I would contact them, and just interview them a little further. But that did not happen because everything everybody was on matched what they said they had. For instance, if they had a heart attack, you would expect them to be on some sort of a nitrate or nitroglycerin, and everything matched. So did not have any suspected people, and you would really have to think who would go in there and do all this work if you weren't a real heart patient. Other limitations is the sample is not representative of the U.S. Census. There's more females, less minorities, and fewer lived alone than the actual population in the U.S. At the time the study was done, not most people have computers now, but most people have access to the computers. At the time, it was more of a social status type thing, so that younger people or poorer people may not have had access, and that may have skewed the sample a little bit. Recommendations. To replicate the study with more repeated measures and patient acting as their own controls, which is to eliminate the self-care group, and also with other diagnoses such as cancer and diabetes to determine different intervention strategies. So in this, what would happen is that everybody would get the support. They would either get it in the beginning or at the end. Even though we offered it to the self-care group at the end, a lot of people did not want it, but so we were thinking it would probably be better to have it all built in, and then you would either get it at the beginning or at the end, and then you knew that all from the beginning. Other recommendations are secondary analysis by age, gender, and diagnosis, secondary qualitative analysis, recommendations for practice. An online intervention can be used to affect psychological and physiological outcomes, can be an invaluable opportunity to educate the patient, and can be a good form of outreach to rural and underserved populations. Recommendation for education is to teach the next generation of students about online intervention, and have an online clinical where you're actually assigning patients online and having students interact with them. For administration, issues with program setup, evaluating the program, usability of the program, nurse licensure and contingency plans. And this has become an issue most recently with insurance companies. They're providing telehealth services to patients in different states. So then, does the nurse need to have a license in the state? If somebody in Massachusetts is talking to a patient in Nebraska, does she need to have a Nebraska license? So those are all, some of the states have nursing compacts where they have, agreements with each other's. There's like 16 states that are all joined together in one compact. But say you're not in one of those states, how does that impact the provision of nursing services? This study was supported by the Agency for Healthcare Research and Quality. This was a doctoral dissertation grant, American Nurses Foundation grant, Sigma Theta Tau International grant, and Yale University General Clinical Research Center provided informatics support. Any questions?